Good morning. I'm Roger Blumenthal, Professor of Medicine. Welcome to the Diabetes Virtual Education Summit presented by Johns Hopkins University School of Medicine and CardioCare Live. My name is Dr. Roger Blumenthal, and you're tuned into a live session called Present and Future Perspectives on Diabetes Prevention. I'm very pleased to be here with my colleagues, Dr. Lawrence Apple and Dr. Tom Donner. Dr. Donner is an Associate Professor of Medicine at Johns Hopkins School of Medicine and the Director of the Johns Hopkins Comprehensive Diabetes Center. Dr. Larry Apple is Professor of Medicine and Director of the Welch Center for Prevention, Epidemiology, and Clinical Research at the Johns Hopkins University School of Medicine, and a recent inductee to the Institute of Medicine. He's also a fabulous trombone player. Before we get started, I'd like to remind our audience that we will be taking questions in real time throughout this presentation. You can send me your questions anytime during the program through the box in the lower left-hand side of your screen. And we're real pleased to have Dr. Apple and Larry. Why don't we have you go ahead and get started?
Okay, great. Well, thank you for the opportunity to participate in this forum. The title of my talk is Present and Future Perspectives on Diabetes Prevention. I have one conflict that I need to report. It's an institutional conflict of interest with Healthways, a company that is developing a weight management system. I also want to acknowledge three colleagues who provided some of the slides that I'll be showing today. Okay, let me cover or provide an overview of what I intend to cover today. So the first topic will be type 2 diabetes and the role of adiposity and genetic factors. Second, will be discuss briefly the pandemic of obesity. Third, lessons from 20 years of research on weight loss. While I direct the Welch Center now, I spent most of my investigative career trying to understand factors that determine cardiovascular and metabolic risk, and have done several trials on lifestyle modification, and I have several insights I'd like to share with you that would be relevant for clinical practice. And finally, very basic question, what can a doctor do now given the problem of diabetes and how we and options we have to prevent it? So this slide is one of many that display the relationship of type 2 diabetes. What's important about this particular study is that obesity both in youth and in adults is associated, are each independently associated with developing diabetes. We can't start too soon, and is a major reason for why we focus on children, not just on adults who have developed obesity. But that's not the only source. I would say obesity is probably the primary determinant of type 2 diabetes, but there are genetic factors that have been identified in a variety of different types of studies. And this is a slide from Dr. Goldfarb, who documented on this slide at least the first 37 variants that have been identified with an increased risk of diabetes. Since then, there have been close to 30 more variants. Interestingly, each of these is associated with a relatively modest increase in risk of diabetes, and also even if they are commonplace. So it's not as though this is the smoking gun in the diabetes epidemic. There was an interesting article that looked at the joint relationship between obesity and diabetes and genes. And if you look at that first blue row, which is the displays the risk of obesity or risk of diabetes in people who are obese with few alleles, you'll see a dose-response relationship. And if you look in the opposite direction where the colors go up, you also see that that the risk of diabetes increases with the number of alleles, and it is there is a interactive relationship, such as the greatest risk, of course, is individuals who are both obese and have, in this case, greater than about 10 alleles for that were on the previous slide. So where do we go with genes? Well, I think we can look for additional common variants that that are associated with small risk. There might be a few variants that are associated with larger risk, but these are not likely to be account for the scope of the diabetes epidemic. We of course can look for gene-gene interactions and gene-environment interactions, just as what I showed you on the last slide. I think epigenetic effects is actually quite interesting and might be certainly a fruitful area of investigation. And the idea of epigenetics is that our genetic material, while our DNA is stable, there are features of our genes that are not stable and that might change with environment, such as diet. And so we have colleagues that are at Hopkins are very interested in this, and I think this is a fascinating area of research. And of course, we can identify novel targets for drug therapy. But the real smoking gun for the diabetes epidemic is the obesity epidemic, and in fact, many people conflate the two together. Given that when you look at the epidemiology, you find that basically those populations, those countries with a high fraction, a high prevalence of obesity also have a high prevalence and incidence of diabetes. And this slide just summarizes what we have seen in the United States, which is from in this case 1991 up until 2007, just a marked increase in the prevalence of obesity and a striking increase in weight, on average 7.8 pounds for men, nearly 8 pounds for women over this time period.
Larry, there's a question that actually just came in. Maybe there's a slide up there.
Sure.
Dr. Wilfork actually had a question for Dr. Donner. He said, looks like those represent the SEC schools in that southeast here. And what is the approach, Tom, to individuals, say, football players who are real big and gain a lot of weight and are prone to diabetes, and when they stop playing, what do you do when people who maybe were competitive athletes and very heavy and now they have type 2 diabetes? What's your general approach?
Yeah, so this is a common problem because they were able to get away with that extra weight because they were so physically active and improved their insulin sensitivity. But once they stop becoming so physically active, glucose levels will rise, especially with progressive age. Mm-hmm. And so you either have to increase activity or you need to find ways of losing weight. Otherwise, they're going to need medications if they're predisposed to diabetes and their obesity is leading to diabetes.
Yeah. There's actually a more common issue than the elite athlete who suddenly becomes more sedentary, and that's in the military. When individuals who are deployed suddenly end their deployment, there's a marked spike in obesity that occurs at that point, and the armed services are increasingly interested in this phenomena and trying to prevent that because it affects tens of thousands of individuals at that particular point. But that's a great question. I actually think that going to school at the SAC is a toxic phenomenon. That's what I would say. But so the problem, by the way, as highlighted here, is also it's worse in children and minorities. These figures on the right actually pertain to prevalence of obesity in adults. And as I'll highlight in a subsequent slide, the problem is worldwide, and the rest of the world. Actually, some parts of the world have actually even caught up and gotten worse, particularly the Gulf region and the Middle East. So these are slides that display the prevalence of obesity in whites in the panel in the upper left, blacks in the panel on the upper right, and Hispanic. And the problem is much worse in particularly blacks, and in particularly black women. That's where obesity and morbid obesity is extremely common. This is the pattern in children, and if you just look at the set of bar graphs on the left, that's children 6 to 11, and you see over 3 time periods the prevalence of overweight has nearly tripled in children 6 to 11, and the same thing occurred in children aged 12 to 19. And this highlights what I think is an important public health message that we need to start early. And then also, I know that many people many of the practitioners are adults, treat adults, but I think that the message should also be that families are at risk. And so what we tell our adults, or in terms of advice, I think might have some downstream effect on our children.
Larry, just a quick one. Dr.
Sure.
Joseph Adams wanted to know how much of that do you think was due to decreased physical activity versus just an increase in calories, and is there any way to sort of tease that out?
That is the Achilles heel of our research, and we don't have great metrics either for measuring total caloric intake in a population and for measuring physical activity. But the best I think the best data suggests that that caloric intake has increased by over 200 calories in children on a daily basis. And that is probably enough to account for the rise in weight that we've observed. Some people have thought that it just takes an average calorie difference of 50 calories per day to lead to our observed increase in obesity. So right now it's over 200 calorie increase, which, by the way, happens to be the average caloric intake from sugar-sweetened beverages right now. And so that's why I'm focusing mostly on clinical matters, but in terms of public health matter, I think trying to reduce sugar-sweetened beverages is getting at what I think is one of the main culprits in children. Physical activity, though, it has declined, but I don't think it's the primary.
One follow-up, Dr. Adams and Dr. Belichick were wondering if there's any good websites or places where you recommend that patients with type 2 diabetes go to sort of keep track of how much calories they're taking in, how much they're burning up, or do you recommend pedometers, or what sort of practical things might you have?
Yeah, so a number of websites are available out there, and I don't know if this is something we could post later on. I can't rattle them off the top of my head. Pedometers, you have to individualize. If an individual patient would find that beneficial, I suggest that to patients in terms of trying to get that 10,000 steps in during the day, and many of them like to have that feedback in terms of how well they're doing during the day. So I think that's excellent.
Sure.
An excellent idea.
And actually, in one of my slides, I'll show you just an approach to sort of self-monitoring, where you could, in addition to tracking weight, minutes of physical activity, you could replace minutes of physical activity with pedometer steps. It's a very simple approach.
Great.
Let's go ahead to the next slide. So, obesity worldwide. I'll just briefly cover this. This is a figure that displays the prevalence of overweight and obesity, men and women, and I hope that you can see that on your individual computers. But if at the very top, there's a cluster of countries in the Gulf region that really are leading the pack right now, and those are countries like Qatar, United Arab Emirates, Saudi Arabia, among others, where the obesity rates are just enormous. And in this case, it is a combination of excess caloric consumption and physical activity. So here we are at the center. We can try to manipulate genes. We don't actually have any therapy right now that is available, or we can work on the environment. So the environment. What is it about our environment that leads to obesity? Well, I think, and these are just a partial list, but I think these are some of the main players. One is food availability. abundant, inexpensive calories, and secondly, massive increase in portion sizes that I'll show. 2 points. We are a part of the problem. I've been at many events, not just at Hopkins, but also at professional societies where calories are just available at almost every point you turn. Portion sizes as well. We're now serving bagels and muffins that provide close to 500 calories, and this is, for many, might be a second breakfast if they've eaten breakfast already at home. Second, sources. We now are consuming very calorie-dense foods, low in fiber, high in calories. And a second, liquid calories, which I think are underappreciated as a source of excess calories in our diet. And we don't probably have the regulatory systems in place to sense these calories. So we consume them very quickly, and we don't get a sense of that we are satiated, and so we still consume more. And so there's good biology to support that. Very difficult to prove, at least in clinical trials. Decreased physical activity, pretty clear. We have a lot of labor-saving devices. Our built environment is really very bad for being physically active. And finally, a big concern of mine is that we now have a change in what we consider normative behavior, and there are instances in which, very prominent, where there's a glorification of excess caloric consumption. It's now become popular and maybe even normative. So when I was preparing to give a talk in Iowa, I went to the website for the Iowa State Fair, and actually I was prompted to this because it was, I even heard about it on the radio, and they really go out of their way at this particular fair to identify novel ways to consume calories. So this is the Blue Sapphire Funnel Cakes. Notable not just for its content, but it's for its size, if you look. And this is gourmet chocolate cake, battered, deep fried, and topped with homemade icing and powdered sugar. The Nothing Spared Fair Square, marshmallows, crisped rice cereal, pretzel, potato chips, Oreos, and M&Ms. Here's one of my deep fried butter. This is might be entertaining, but it's unfortunately a sign that we have glorified certain aspects of our culture that would lead to really not just excess calories, but also food that I think is intrinsically unhealthy. So in terms of portions, here's a great example, and these are from the NHLBI website called Portion Distortion. Shows you the change in caloric intake just based on changes in the size of some of the foods we consume. So it's a bagel 20 years ago on the left, 140 calories, and on the right, bagel today, 350 calories. That's what I ate yesterday for cereal or for breakfast. And if I ate normal, and it's interesting in terms of there's a lot of behavior that goes into the amount of food that we consume. So sometimes we eat because of hunger, but often we eat what we are served. And so there have been many experiments, including ones done by Barbara Rawls, that show that you just consume what's put in front of you. This is and when you portion size that they're so that have increased so much, you can understand why caloric intake have increased. Same thing with soda. Typical caloric beverage 20 years ago, 85 calories, now 205. Again, just under 200 calories. Okay, so now I want to move on to some lessons that I've learned from conducting research on weight loss. The first is that modest weight loss can prevent type 2 diabetes in high-risk individuals. These are the main results from the diabetes prevention program done at many centers across the country, including Hopkins. It tested lifestyle modification, which focused on weight loss and physical activity. A second group that got metformin, which is a drug that lowers blood sugar. And third, placebo. And interestingly, lifestyle was the most effective. That's the lower line, and it shows you the incidence of diabetes over the course of 4 years. And metformin, interestingly, was in between. Long term, there was still a benefit, although it's somewhat attenuated, and that's in part because the placebo group in the study was given the opportunity for lifestyle change. Weight was probably the main driver of this relationship, and it might be even that the benefit of metformin, although there are probably drug-specific effects, that the reduction in weight that occurred, modest reduction in weight that occurred from this, or associated with the use of this drug, led to the reduction in diabetes that I showed you earlier. A second important point, and one that's very relevant to clinical practice, is that older age individuals can achieve and sustain weight loss. And these are results from a clinical trial we did called TONE, in which individuals were randomized to weight loss or no weight loss. And on average, individuals who are age 60 and older were able to lose roughly 4 to 5 kilograms of weight and keep it off over the course of 2.5 years, which differs markedly from the experience that we see in middle-aged adults where there's weight loss followed by regain. This was even better documented in a trial called Look Ahead, where they had younger, middle-aged, and older adults. And these are the percent of individuals who lost roughly 7% body weight. And the group that was least successful were people like Roger, who are in the 45 to 54-year-old category, and I'm in the middle category there. I don't think Tom's in the one on the right. But anyways, those that lost those that were older age were more successful, and this actually echoes the experience of most researchers who attempt behavioral or lifestyle interventions. Older age people do very well.
Larry, there's a question here from
Sure.
Dr. Brady and Dr. Montgomery. Just wondering if Dr. Donner has any insight into the Look Ahead study. From what we understood, was stopped recently because it didn't show a decrease in cardiovascular events, but did show an improvement in glycemic control. I didn't know if you might want to comment at all about that.
Yeah, so, and that's actually true of a lot of our intervention studies looking for cardiovascular outcomes. The problem with many of these trials is that not everything else stays the same. And so one would expect over time that with improvements in weight and reductions in glucose levels, improvement in lipid profiles, blood pressure, you'd see cardiovascular benefits. But so many of the patients in all groups now are more aggressively treated with for blood pressure and lipids that our event rates are lower. And I think that's part of the problem that we have with many trials now. It's hard to tease out any one intervention because the other risk factors are the management of those is not static.
Sure. Yeah, the paper hasn't been published yet, but the risk factor data are along with the medication use, and I looked at those. It's interesting that. Part of the problem is, they went their procedures screened out the sickest people, the ones that were most likely to have cardiovascular disease events. Everybody got an exercise stress test, so it was a low-risk group of diabetes. And then secondly, the people in the study, the trial didn't control risk factors, so people in the intervention group had improvements of blood pressure, and those in the control group had more aggressive medications added on both for all the risk factors. So there was really a convergence. And so I think what the important thing with that trial is it's going to test an intervention, but it didn't really test the issue of is weight loss associated with CVD. I think that question is the key issue. So anyways, let's move ahead. So a third lesson is that weight loss differs by race and gender, and these are weight loss results from a trial we did called Weight Loss Maintenance Trial, and this is the first phase where everybody got a weight loss intervention. So we had a very good balance in terms of large numbers of African American men, women, so we had a very broad distribution. And this is what we documented in weight loss maintenance was the general experience, albeit in smaller studies, which is that non-African American men do very well in weight loss studies. And the group that has the greatest challenge is African American women. But I would also highlight that at least in this trial, where we're using contemporary methods to achieve weight loss, African American women actually did pretty well compared to previous studies where there was little or no benefit. In this case, it was 4.2 kilograms of weight loss. Now, if you don't do anything after that initial weight loss, this is the pattern you'll see, which is weight loss followed by regain over time. But interestingly, over in this slide 2.5 years, but we actually have 5-year data, doesn't return back to normal, back to baseline. So there is reason for, I think you would say the glass is half full, that there is on average some continued success despite the regain in weight. Now you can you can sort of blunt that to some extent with counseling. In this case, we provided counseling by phone and in person once a month for an addition for that 20 for the 2.5 years, and so you see a net benefit of about 1.5 kilograms, and so it didn't keep people at their initial or at the level of weight they lost, but it was partially helpful. And the group where we didn't get any clear benefit was use of internet or web-based intervention. And I think this is the experience that many groups have, is that technology is very exciting, and I use my iPhone, I use a computer, but by itself, without any person-to-person counseling, it's not likely to be particularly effective as an intervention. What we tend to do and believe and implement in our current interventions is a combination of some type of person-to-person counseling supplemented with technology like use of interactive website. Very important point that I think that a lot of patients are interested in different types of diets, as diet rich in protein lead to greater weight loss, and that's not the case. Diets that emphasize different macronutrients do not lead to different weight loss, and this is results from a major study called Paulins Laws by a colleague, Frank Sachs of mine. This is a trial that tested 4 diets. The diet on the right emphasized more carbohydrate, and the diet furthest on the right emphasized more protein and fat, and the ones were in between were intermediate. And they tested this in 800 overweight, obese individuals, and this might be difficult to read, but each of those clusters of lines are different periods: 6 months, 12 months, 18 and 24. And what you see is the diets led to the same level of weight loss. And so it's not perfect evidence that a calorie is a calorie, but to me, at least when it comes to the behavioral counseling that we try, the emphasis should be on calories and not really focusing on replacement of one type of calorie with another type of calorie.
Larry, quick question. Dr. Agustin wrote in and Dr. Woodhead wrote in, just wondering what your thoughts were about low glycemic diet, and do you think certain types, is that a good concept? And also for Tom to comment about, does that, following a low glycemic diet, does that help people fill up quicker?
So that's an interesting issue. We've completed a feeding study, not a weight loss study, of diets with different glycemic indices and also different carbohydrate levels on cardiovascular risk factors, including insulin sensitivity, and the results of that trial will be forthcoming, but were pretty null. The issue comes when for weight loss, and I think there might be a benefit, but I'm not sure if it's the glycemic index per se or some other attribute. We haven't really, the nomenclature and the nosology for carbohydrates is still in flux, and so while some people focus on glycemic index, other people will say the real issue is just the amount of bulk, the amount of fiber, and if we really just had high fiber diets, the glycemic index potentially wouldn't be as important. Might be a bit of both, but it's very interesting because in the United States, the major policy-making committees like the Dietary Guidelines Committee have not placed much stock on glycemic index, at least as a attribute for which we would make recommendations, while the opposite is true in Australia, where that is like one of the #1 attributes of diet that is focused on in national recommendations.
Tom, we got a hot button here. Dr. Ornish, Dr. Mayo, a few others have written in about vegetarian approaches versus low glycemic diet, and what do the dietitians and endocrinologists at Hopkins typically recommend?
Yeah, so I think our perspective is the same that Larry just presented, is that it's the total amount of calories, and you need to individualize a diet program that's going to work for a particular patient. I prefer lower glycemic index foods because you don't get this spike in blood sugar as much, and so you will see a benefit in A1C. Now that's going to translate to benefits decades down the road by improving A1C, but still it's a benefit, and especially in younger patients, that's important. But we tend to we certainly encourage a vegetarian diet because in patients who can stay on it, there appear to be benefits in terms of weight and glycemic control. So we don't discourage that, but I think it's hard for the majority of Americans to go with one extreme or another. They just tend not to stay on that type of a diet.
Yeah.
Great.
Okay. So getting back to sugar-sweetened beverages, there's, I think, an emerging body of evidence. It's not a perfect body of evidence. It's very difficult to test, but reducing sugar-sweetened beverage does appear to reduce weight. And these are observational analysis that we did nested within a clinical trial. And the people who lost the most weight were those that had reduced their sugar-sweetened beverage intake the most. And these are data in adults. Now, recently, there were 2 trials that were published in New England Journal that tested whether a reduced intake of sugar-sweetened beverages might prevent weight gain. And actually, both of those, I think, support this. So I think, and also support the public health initiatives that I mentioned earlier. Lastly, and I think very important to how we deliver interventions, remotely delivered interventions can be as effective as in-person interventions. And these are results from a trial that we published a year and a half ago. And so this was a randomized clinical trial. There was a control group, and then there were 2 interventions, a remotely delivered intervention over the phone, and then an in-person intervention, which actually was more of a combined. There were group meetings, individual meetings, and also use of the telephone. And like many sort of like contemporary trials that we call pragmatic, we gave individuals the flexibility. And so even though we termed it in person, it turns that many people actually preferred the telephone. But anyways, in the remote group, the Healthways coaches delivered the intervention. There was coach support that we provided. There was a website, and then the physicians provided a supportive role. They weren't the primary coaches. The in-person, as I said, had group, individual, and telephone contacts. The coaches were Hopkins staff. Interestingly, none of the coaches were really, none of them were PhD level behavioral interventionists. These were actually some people were actually very green in terms of delivering interventions. And these are the main results. Control group lost a little bit of weight in this study, but both the in-person and the remote groups lost on average roughly 4.5 kilograms of weight, and interestingly, it looks like they kept it off over time. And a lot of speculation about why that occurred, but it might have been the use of the website in addition to the coaching, because people had to go, they were advised to go to the website every week to enter their weight, and then they would get some feedback based on that weight. If they didn't go to the website, then they would get an email reminder to go to the website. So it's very difficult and expensive to maintain an intervention over time, but particularly person-to-person intervention. So some combination of person-to-person contact with frequent reinforcement and contact with vis-a-vis website is probably the way to go, and might lead to sustained weight loss. So now I'd like to end with what perhaps is most practical aspect. Well, what can a doctor do to promote weight loss? So we have, I think, 3 options to consider. Promote behavioral change, which I think we can do to all of our patients. The issue is whether we do it ourselves and or through structured programs. Second option is to prescribe medications, and a third option is to order bariatric surgery. I'll spend a little time in the latter 2 options. I'm not an expert in that area, but I think those options are available. Instead, I'll focus on promoting behavioral change, which I think is really the linchpin. So There are different approaches to identifying individuals who are candidates for weight loss intervention. I think busy practitioners have to focus on people who are at some level willing to make changes. So these are people who, if you follow the Prochaska sort of stages of change model, that are contemplating, they're considering making a change, they're preparing to do it, they've actually made some step, or they've or action. They're doing something right now. Many people, this might not be perfect. One thing that we've found, and I think is very common, is that people move between these. And so even in our weight loss clinical trials where we think we're getting highly motivated individuals, they may become less motivated with time, or when they realize that serious changes to lifestyle have to be made. I like thinking about SMART goals. I think this is a useful approach towards almost any behavior change. You need to be very specific about what you want the person to do, ideally measurable, attainable, realistic, and within a certain time frame. And this was done. This can be done for physical activity. It can be done for weight, and so. For realistic goals for weight, we aim for a healthier weight, not ideal weight, and as I pointed out earlier, modest weight loss can be beneficial. So we tend to promote slow incremental progress to a goal. Initially we typically have an initial period of aggressive weight loss, followed by a maintenance period. And during that initial weight loss period, we aim 5 to 10% weight loss, which roughly 1 to 2 pounds per week. And then the subsequent goal is really maintenance of weight loss. If you can sustain the weight loss that you achieve, that's success. I know some people say, well, I want to lose more. It actually turns out to be an unusual person that is able to continue weight loss beyond the initial 6 months. So why 1 to 2 pounds per week? It is achievable. It corresponds to roughly a 500 to 1,000 calorie deficit. That's the part that is challenging. A 500 calorie deficit day after day is very difficult. May be difficult for individuals. It is safe. There might be problems with rapid weight loss. Perhaps one problem might be a risk of gallstone attacks. It also doesn't require close monitoring, but there is one exception, and that is people who have type 2 diabetes and who are on certain medications that increase the risk of hypoglycemia. So, for example, if an individual is on insulin or on certain oral hypoglycemic agents like glipizide, your people are going to have monitoring of blood sugars, especially if they lose weight. In our clinical trials, the POWER study and also the Look Ahead study, which we did here at Hopkins, there were people actually lost weight and they came off their they had dose reductions in their diabetes medication. So I think that's a very important caveat that has to be emphasized. Here's an example, by the way, of a SMART goal. So a SMART weight loss goal. I will lose 4 pounds in the next 2 months by walking 30 minutes per day in the morning, substituting diet soda for usual soda that I drink, and by eliminating desserts. So trying to get as specific as possible, measurable as possible, and then the key issue is then how do you sort of implement this? And I'll show you actually what I do myself on a daily basis, which is on this slide. So I participated in a pilot study and in which I was supposed to monitor weight and physical activity. And so I still do this now. It's the first page of my daily task list. I write down actually each week what days of the week I'm going to exercise. Usually I exercise 3 to 4 days a week. And I indicate how many minutes of physical activity. I also will weigh myself daily. I put the weight on this basically it's a printout from my email from Outlook. But you can go to calendar.pdf and you can print out blank calendars. And so putting on the calendar what your goals are for the week, what you actually do, and then you reconcile this. And I think it's an easy way to track key behaviors like weight management and exercise. So there are now, there's been a recent development, I guess it was just over a year ago, the Centers for Medicare and Medicaid Services actually did approve behavioral therapy for our obese patients, and they're actually, this has to be operationalized. I think people are still a bit scratching their heads about how they're going to do this and implement this in practice, but it includes screening, dietary assessment, and individual or intensive behavior counseling. That is based on the 5A framework. If you read their document, assess, advise, agree, assist, arrange. And then there's a contact pattern that's proposed. The challenge is the reimbursement, which I don't think is adequate for one-to-one counseling, but could be feasible if you were to implement this perhaps in a group type setting. There are many caveats to the reimbursement process. It does have to be delivered by primary care physicians, and it can't be done primarily by nutritionists and other personnel, which I think are probably the better group to implement this rather than primary care physicians. One word about weight loss medications. There have been many on the field, and almost as many that have been taken off the market, often for serious adverse effects. There are two that have been recently brought to market, and they're listed on this slide. I tend to be skeptical about their role in the epidemic, but in dealing with the epidemic, but might on an individual basis be considered. Finally, bariatric surgery, and these are data that were just published this past year from, it's not a randomized trial, but it's the closest thing to it. It's the Swedish obesity study. It's a study of individuals who got bariatric surgery, a variety of types, and individuals who did not get bariatric surgery. And they followed individuals over really almost 8 years, I believe, near 10 years, and very few of the individuals who got bariatric surgery developed diabetes, in contrast to those that did not, and the risk reduction appears to be 80%. I doubt that there will ever be a definitive trial of bariatric surgery and diabetes, so this is probably the best you're going to get for many years, likely decades. Now, whether it's all related to obesity, I can't say for sure, because there are many hormonal changes that occur that related to gut hormones that might account for these findings. So it's probably not just the sizable weight loss, which often is around 25% of baseline, that accounts for this. That's, but I think for certain patients that is an option. So here's some take-home points. Prevention of obesity is key to prevention of type 2 diabetes. Modest weight loss has beneficial effects, including a reduced risk of type 2 diabetes. Physicians can have a valuable role in promoting weight loss. Research is needed on the optimal strategy to achieve and sustain weight loss, particularly in the office setting. And then the scope of the obesity pandemic is really massive and warrants environmental approaches. And so the approach, for example, in New York to reduce the portion size, I think, is a step in the right direction. Thank you very much for your attention, and welcome your questions and thoughts about this topic.
That's great, Larry.
And I have one cartoon, which I think...
sure, please do.
Yeah, and it's, I think, appropriate for our intensivist. It says, I was able to get one more lecture on diet and exercise.
Right, in the ICU.
In the ICU. So,
Great.
Thank you very much.
So, Larry, that was fabulous. So Dr. William McPeck and Dr. Josh McDaniel both had similar questions. And Tom, maybe we'll start off with you. What thoughts do you have for helping the individual who says won't comply with writing down what they do in terms of calories and figuring out how many steps they take a day? What are the key messages you might tell a patient with type 2 diabetes?
So I guess I'm not understanding the gist of the question in terms of those patients who aren't willing to take the lifestyle measures.
If you tell the patient 10,000 steps
Right.
and count your calories so that they're less than 1,700, and they say, "Doc, just don't have time for that." What's your next bit of advice to that patient?
I think patients have to be part of the care plan, and you have to open up the discussion in terms of what they're willing to do. And our job on the physician side is to show them the evidence for the modalities that are available and what is likely to be effective, and provide encouragement. But we can't be there with them every day and say you have to do this. And so I'll sometimes have family members come in so that they're on board with it. The lifestyle things that we're talking about is good for the whole family. So if you can have both the spouse involved in a similar program, that's obviously useful. But this is a challenge. I think compliance with lifestyle measures is a huge challenge, and there's no easy answer. I think Larry, you have any thoughts?
I think we should separate the self-monitoring piece from the behavior, some of the behavior change. So the self-monitoring of calories is a challenge. It's a multi-step process. It takes a fair amount of work. But the repeated evidence that the greater that an individual monitors their calorie, the more likely they are to lose weight, and it's been shown in several studies. I think an alternative, if somebody doesn't want to measure calories, is to just weigh themselves daily. Because it's not a measure; it's actually a measure of caloric balance. Aside from sort of some fluid shifts. So if somebody is going in the wrong direction and they're monitoring their weight daily, they'll know it. In fact, many studies, Rena Wing has done several studies that are based on what they call the self-regulatory approach, and they're really using the scale as the trigger for when to be more aggressive, be more concerned. I think that might be an alternative.
Larry, Dr. Frida Alim and Dr. Aaron Hernandez wanted to get your thoughts about how good is diet soda, and does the fact that these sweetened beverages, do they sometimes still stimulate the appetite, and is it better to talk more about water or bottled water than, say, a diet soda as a substitute?
You probably note that we are drinking bottled water here, so that's probably
I thought yours was Scotch. No, not Scotch?
Gin.
Okay.
It's a hot area. I think that there have been observational studies now that associate diet soda also with weight gain, but I think that's a bit of the reason for that is these are people also have made changes in response to their weight, so I'm not sure that that association is causal. But the core issue is are you persisting in stimulating a behavior that is trying to consume sweetened beverages when maybe what you're should do is to just try to in some way encourage behavior to consume non-sweetened beverages. So there are a lot of now sugar substitutes, and they're almost indistinguishable now from sugar, and it might in the end lead to, I think, continued calories consumption. I don't think there's any reason to. There's no dietary requirement for diet soda, so
Gotcha.
I would very much push for water as a primary.
So, Larry, Dr. Devin McCourty and Dr. Henry Mileman wanted to know, how do you move patients from the contemplation stage to the action phase? What's your advice to get them to go from that contemplative phase to actually taking action and making changes?
That's a tough one, and I don't think I have a good answer to this. Part of the problem is that we, as physicians, we focus on those people that are most eager to make changes. They're the easiest people to work with, those that come to us and have. One thing that has sometimes proves effective, but anecdotally, is just is documenting the consequence. Like when you were, when your weight was 20 pounds less, your blood pressure was lower, and you're on the edge of potentially being on medication. It's a tricky message, though, because I think that can be effective where you show for that individual. So there's been a change, and that change has had consequences. The one thing at least when it comes to medications, I try to be careful not to demonize medications, because quite frankly, we have stronger outcome data and trials for medications. But I know that many patients like to minimize the amount of medications that they take, so that might be one way.
Tom, last question for you from Dr. Meileman and Dr. Welker. Besides metformin, do you ever consider any other diabetes medicines to delay the onset of diabetes? Would you ever use a glitazone? Would you ever use a GLP-1 agent?
Sure. So if you look at most drugs that are diabetes medications, you will delay the progression from pre-diabetes to diabetes. So you have to start looking for side effects of drugs. So the pioglitazone or the triglycerides lead to weight gain, which is obviously not desirable in this population. Metformin just has such good safety data, and it also has apparently cardiovascular benefits, weight benefits. So if I'm going to use a drug, I would go with metformin. The other ones, the side effect profile either won't be tolerated well, or it's just not acceptable when we're trying to prevent a disease from occurring.
That's fabulous. Well, this has been a great presentation. I wanted to thank my good friends and panelists, Dr. Donner and Dr. Apple. I wanted to thank Boehringer Ingelheim and Amylin Pharmaceuticals for their support of this important educational series. Please remember to complete the quiz at the end of the session to secure your CME credits. And stay tuned for the Interventional Cardiology Summit session, assessing progress in coronary stenting with Dr. Greg Stone of Columbia. My name is Dr. Roger Blumenthal. Enjoy a heart-healthy, small-portion lunch and to eat something that Dr. Apple would be proud of. So thank you very much for your attention, and enjoy the rest of the afternoon.